Hello everyone. Today I'll be showing this case, the Phaco in a no glow. She is a 57 years old patient with no history of injury or hypertensive or diabetic, and patient came with a no glow. And as you all know, it's so difficult to do the surgery where there is hardly any retro glow. Now we are doing the Phaco emulsification. We use Venturi system. Now once the nucleus is eaten up, now we'll be using bimanual irrigation and aspiration, removing the cortical matter. And even removing the cortical matter, you can see in the center there is no glow. So once the cortical cleaning is done, we fill the interior chamber with Helon and air bubble. Now we are doing the endoscopic vitrectomy. See the amount of the vitreous hemorrhage intraocularly, and still there is no glow. Now here we can see the retina. We are doing the vitrectomy, removing all the membranes along with the vitreous hemorrhage sheets. These type of cases becomes really difficult where there is hardly any glow. Now a little bit of the illumination, you can see the retina. But if you see here, something is pushing behind from this thing. This is a choroidal hemorrhage. Now we are doing the vitrectomy. We are touching the with the vitrector. We are just feeling it. In spite there is no RD in this. Now we are using the PFCL to in order to flatten the retina. And the most important point I would like to highlight, when you put the PFCL here, so you are shifting the hemorrhage to the periphery. So in my experience, fill with a nice PFCL so you can shift the whole of the blood to the sclerotomy side. Now you take the look of the visualization. Now at the periphery you will see there's a dark gray as if the whole of the blood is shifted. And endoscopy gives an excellent tool, especially in this type of patients. This view cannot be possible in the standard vitrectomy, and especially the peripheral area as well also. Macular region is okay. One can always do the photocoagulation if required. The most important thing in the endoscopy, you can take a look of the 360-degree inside the eye and especially the retroviridal area. Now you see the choroidal hemorrhage and you can see the border, it's totally demarcated. The retina is flattened underneath and you can see the whole of the choroidal at the peripheral. Now we are filling the PFCL to top level. And some bubbles can be during a suction. With the vitrector, we can remove the suction, the bubble. Now we'll be draining the hemorrhage. See the amount of the hemorrhages, and here what we can do, either you can refill with the PFCL or increase the pressure of the irrigation fluid or the air tamponade. Just you have to push Just a little bit of pressure over the sclerotomy site, and whole of the drainage of the hemorrhage will come automatically. Once the this drainage is done, now see the pupillary area, so you'll have a little bit of glow. Now see the glow has come. Now we'll be doing the drainage from the other sclerotomy site. The glow has increased. The PFCL can be removed and air tamponade can be given. Sclerotomy site should be closed, and hopefully the patient will get restore her vision.